Basics description: intraluminal colonic tissue growth. Most commonly sporadic or part of polyposis syndromes, generally slow growing with low malignant potential, due to high prevalence in population. However, resection is generally recommended to eliminate risk. Size classification. Diminutive is less than or equal to 5 mm, small 6 to 9 mm, large is greater than or equal to 10 mm. Morphologic classification. Depressed, flat, sessile, or pedunculated. Clinical significance. Greater than 95% of colonic adenocarcinomas arise from polyps. Epidemiology: colorectal polyps are more common in non-Caucasian men in Western countries. Incidence increases with age. Prevalence: 15 to 20% of all adults, 30% of U.S. population greater than 50 years, 6% of children, 12% of children with lower gastrointestinal bleed. Etiology and pathophysiology: mucosal, neoplastic adenomatous polyps, tubular greater than 80%, villous 5 to 15%. Tubulovillous 5 to 15%. Serrated polyps: sessile serrated polyps are common, more in proximal colon, with low malignant potential if no dysplasia and significant malignant potential if dysplastic. Traditional serrated adenoma is uncommon, more often noted in distal colon, with significant malignant potential. Non-neoplastic polyps, hyperplastic, juvenile polyps, hamartomas. Inflammatory pseudopolyps, hyperplastic polyps are very common, more in distal colon, with very low malignant potential. Juvenile polyps are common in childhood, benign hamartomas. More in rectosigmoid, and not premalignant. Submucosal, lipomas, lymphoid aggregates. Carcinoids, genetics: inactivation of tumor suppressor genes as adenomatous polyposis coli, APC, or mismatch repair genes, MLH1, causes polyps to grow into cancer. Familial adenomatous polyposis, FAP, is autosomal dominant. By age 40 years, almost all patients develop colorectal cancer, CRC. MUTYH-associated polyposis, MAP, is autosomal recessive caused by biallelic mutations in MUTYH gene. Juvenile polyposis syndrome, JPS, is autosomal dominant. 50 to 60% of patients have a mutation in the SMAD4 or BMPR1A gene. By age 35 years, 20% of patients develop CRC. Risk factors: family history of intestinal polyposis, polyps, or CRC. Advancing age. Male: high-fat, low-fiber diet. Tobacco use: excessive alcohol intake. Greater than 8 drinks a week. Inflammatory bowel disease is associated with a decreased prevalence of colon polyps, but with higher risk of colon cancer. General prevention: low-fat, high-fiber diet. Avoid smoking. Decrease alcohol intake. Use of NSAIDs and calcium is associated with decreased incidence and recurrence of polyps. No lower rates of CRC with azathioprine, 6-mercaptopurine, folate, calcium. Multivitamins, or statins. Commonly associated conditions: hereditary polyposis syndromes, adenomatous, FAP classic, CFAP, attenuated, AFAP, MAP, FAP variants. Gardner syndrome, Turcot syndrome, hamartomatous, Peutz-Jeghers syndrome, PJS, JPS, familial juvenile polyposis, Cowden syndrome. Alert: JPS imposes a higher risk of CRC. Although juvenile polyps are not premalignant. Diagnosis: history generally asymptomatic, painless rectal bleeding, bright or dark red, mixed with stools, dripping, or on wiping, diarrhea or mucus stool, abdominal pain, constipation, chronic bleeding, resulting in iron deficiency, anemia. McKittrick-Wheelock syndrome, large hypersecretory rectosigmoid villous adenoma. resulting in persistent severe diarrhea, electrolyte disorder, dehydration, and prerenal acute renal failure. Social and family history. Physical exam. Usually normal rectal polyps noted as prolapsed or palpated on digital rectal examination. DRE, fecal occult blood test, FOBT. By DRE is less effective than FOBT by stool passed spontaneously. Diagnostic tests and interpretation. Initial tests, lab, imaging, CBC. Anemia with chronic bleeding. Basic metabolic panel. Electrolyte disorder with hypersecretory adenoma. FOBT. Insensitive screening test, because small polyps don't usually bleed. GUAIAC, GFOBT, uses a chemical indicator with color change in presence of blood. Immunochemical, IFOBT or fecal immunochemical test, FIT, uses antibodies against human hemoglobin. Stool DNA test is more sensitive and less specific than FIT. Diagnostic procedures. Other colonoscopy is the gold standard test for detection of polyps and allows for concurrent polypectomy. Not a perfect screening test, with increased miss rate with right-sided colon polyps, smaller polyp size, low quality of colon prep. Less endoscopist experience. Computed tomographic colonography, CTC, is less sensitive with flat polyps and requires excellent bowel preparation. Double contrast barium enema colon capsule endoscopy. Enhanced optical technologies can potentially differentiate between neoplastic and non-neoplastic colonic lesions. 1a. Enhanced optical technologies include narrowed spectrum endoscopy, narrowband imaging, NBI, image-enhanced endoscopy, iScan, Fujinon intelligent chromoendoscopy, THICE, confocal laser endomicroscopy, CLE, patients with greater than 10. Colorectal adenoma should undergo genetic testing for APC and MAP. 2c. Test interpretation. Tubular adenoma, gross, tends to be polypoid micro. Dysplastic epithelium, tubular architecture. Villus adenoma, gross, tends to be sessile, micro. Dysplastic epithelium. Finger-like projections. Tubulovillus adenoma have a combination of tubular and villus architecture. Hyperplastic polyps are composed of hyperplastic colonic mucosa. Hamartomatous polyps include muscularis mucosa. Juvenile polyp, gross, pedunculated, smooth red mass, 1 to 3 cm. 3. Treatment. Surgery, other procedures. Colonic polypectomy. Diagnostic, therapeutic. Snare polypectomy with electrocautery for pedunculated polyps. Endoscopic mucosal resection for sessile polyps. Endoscopic submucosal dissection. Colorectal surgery. Prophylactic in FAP and MAP and when there are numerous polyps or persistent bleeding. 2, 3, c. Total colectomy. Iliorectal anastomosis. Proctocolectomy. Ileal pouch anal anastomosis. Chemoprevention. NSAIDs and calcium may reduce incidence and recurrence of polyps in patients with FAP and MAP. 4a. Ongoing care. Follow-up recommendations. Follow-up colonoscopy in 10 years if no polyps or distal small hyperplastic polyps, less than 10 mm. 5b. 5 to 10 years if 1 to 2 small tubular adenoma, less than 10 mm. 5b. 3 years if 3 to 10 adenoma if any polyp is greater than or equal to 6 mm. 5b. Or if all polyps less than 6 mm. 5c. Less than 3 years if greater than 10 adenoma. 5b. 3 years if one or more adenoma is greater than or equal to 10 mm. 5. 3 years if one or more adenoma with villus features of any size or with HGD. 5b. 5 years if sessile serrated polyps less than 10 mm with no dysplasia. 5c. 3 years if sessile serrated polyps is greater than or equal to 10 mm or with dysplasia or traditional serrated adenoma. 5c. 1 year if serrated polyposis syndrome. 5b. Patient monitoring colonoscopy for CRC screening starts at age 50 years and earlier for at-risk patients. American Cancer Society, ACS, recommends that people at average risk of CRC start screening at age 45 years through age of 75 years, may extend to 85 years. Based on life expectancy and overall health. Stop screening if life expectancy is less than 10 years. In CFAP and AFAP, screen for extracolonic manifestations, thyroid cancer, dermoid tumors, and gastroduodenal polyposis, every 6 months to 5 years. 2c. In families, lifetime screening for mutation carriers. 2c. In CFAP, with sigmoidoscopy or colonoscopy, every 1 to 2 years starting at age of 10 to 11 years, in AFAP and MAP. With colonoscopy, every 1 to 2 years starting at age of 18 to 20 years after colorectal surgery. Surveillance of the rectum, every 6 to 12 months, or pouch, every 6 months to 5 years, is indicated. 2c. First-degree relatives of patients with JPS require screening by colonoscopy and upper endoscopy after age 12 years. 3c. Diet: low-fat, high-fiber diet, insufficient evidence, patient education. Importance of colonoscopy as a screening tool. Prognosis: regression or no change in size. More with small hyperplastic polyps and with patients on NSAIDs. Recurrence. Juvenile polyps recur in 45% of children with multiple polyps and 17% with solitary polyps. 3. Risk factors for colon cancer. 6a. Polyp pathology: adenomatous serrated with high-grade dysplasia with greater than 25% villus. Histology: polyp size greater than 1 cm in diameter. Polyps located in proximal colon more than 3 polyps. Recurrence rates less than 10%. Post-polypectomy complications: polyps. Progression to cancer: polypectomy. Bleeding 2 to 11%. Perforation 0 to 1%. Higher with endoscopic submucosal dissection. Colonoscopy. Complications related to anesthesia and procedure itself.